I really need to work on my 5-step micro skills today. Gosh, how will I do? Oh, perfect, a student.
Hi, Dr. Thomas.
Hey, how are you? So tell me how that patient in the ER, how did that go?
Yeah, so it was good. She's a 53-year-old female. She's having some chest pain. She's really anxious, though, and I've seen her before, and she's always anxious like this. I think she probably just needs her Xanax.
Okay.
She says she has a burning chest pain, but she has had it before. She's not having any sweating or shortness of breath or anything like that. So I'm thinking that she probably is just really anxious.
Okay. Does she have any cardiac risk factors?
Well, she does have high blood pressure, and she smokes a pack per day, and she's obese. Is that a risk factor?
Yeah, probably. Is there anything on her exam that you noticed?
She doesn't have any JVD. Her heart sounds okay to me, regular rate and rhythm.
Okay.
Her lungs sound clear. I don't know, is there anything else I should have checked?
What about pulses?
I didn't check that.
Okay, that's fine. What about workup?
Well, her chest x-ray looks okay. Her EKG does have some ST depression, but that was there on her last x-ray.
Good.
Her labs are okay, and her troponin is negative.
Okay. Now I want you to kind of tell me about your assessment and plan with this lady.
Well, I think that she really is just having a lot of anxiety. And
Okay.
it's probably atypical chest pain, but I mean, she does have some risk factors, but since she's had this pain before and her Xanax has helped, I think probably that's what's going on.
What about her exam and everything that you heard was reassuring so that you don't really think it's her heart?
Well, the pain didn't really radiate anywhere. Like, it didn't radiate to her left arm or to her jaw like a heart attack might, and she's not having any diaphoresis or shortness of breath or anything.
Okay. I think those are all really good things to think of. Unfortunately, not all patients who present with chest pain will come in with typical symptoms. You know, most of them haven't read the textbook, especially women. I think in this particular patient, we have to be aware that, you know, she's a woman over 50 with hypertension, a positive family history of carotid disease. So I really think you have to say she's at high risk, don't you think? Or what do you think about that?
Yeah, I think that you're right.
Okay.
I guess some of those things I wasn't really thinking about just because she has presented like this in the past with anxiety.
Okay. So let's kind of sum things up. I think you did a great job gathering the information, presenting it to me in a concise manner. Some things I think we can work on. I think your exam skills, anytime you're doing a cardiac exam, make sure you hit the pulses. I want you to not anchor as much on anxiety, especially in women who have a history of hypertension and cardiac risk factors with chest pain. Try not to lean towards anchoring, and then always work on building your differential and not just putting it all on anxiety. But
Okay.
otherwise, I think you did a great job, and I think we got some work to do.
Thank you, Dr. Thomas.
Yes, of course.
So, Destiny, how did things go with that patient upstairs?
So she's sitting up in bed today. She's feeling a lot better from the stomach standpoint. Not nauseous anymore. She hasn't thrown up or anything. I didn't know she's a lot more short of breath, having some like discomfort breathing.
Short of breath?
Mm-hmm.
Why do you think she's short of breath?
Well, she didn't have oxygen on, so I put some oxygen on her. Seemed to do better with some oxygen. But maybe we should do a CT because I think she might have a PE.
Okay, well, what led you to that conclusion?
Well, she had this stomach virus, and then, you know, she's got some swelling in both of her legs, and, you know, just this shortness of breath.
Okay. Anything else on exam?
When I did the exam, I noticed that, you know, she had those neck veins that are swollen.
Neck
JVD,
veins.
I'm pretty sure it's called.
Okay.
And I listened to her lungs, and she had those rails.
Okay. So her neck veins are up, and she's, well, I guess she go see her pretty soon. Have you thought that she might be in heart failure?
No, I really think it might be PE because, you know, she's got those swollen legs and, you know,
Yeah.
tenderness and some problems breathing.
And she's had an echo.
She had an echo previously, and echo didn't show anything. It didn't show it like a reduced ejection fraction.
Normal ejection fraction?
Mhm.
Okay. Well, I really liked your presentation. I think it was really organized, and you paid a lot of attention to the physical exam. One thing to keep in mind, though, is that women over the age of 70 often have normal ejection fraction heart failure. And the fact that she's been here for 3 days and she's been getting normal saline that whole time kind of puts her at risk for heart failure and fluid overload. That's kind of a common scenario. We forget people are on saline, and her neck veins and her lung rales would go along with that.
It does make sense to me now that you're saying all that.
So I really like your paying attention to the physical exam, and remember that neck veins are a much more specific indicator of CHF. And let's don't send her for a CT. Why don't we stop her IV fluids and give her some Lasix and see what happens?
Hey, Dr. Thomas, I just got your text.
Well, since this is our last day together, I just thought we could kind of touch base and go over how the week was and what you thought you did well. So how did things go for you?
I think I did really good this week.
Okay. Can you think of a couple things that you think you did well?
Well, I think I do really good at taking the history. I really like talking to patients and getting all their information and finding out about them and organizing it. And I think I do pretty good at presenting too.
Yes, I did notice that. Your history and physicals are very complete. I like that your HPIs tell a really good story and that you go over all of the old card stuff, you know, onset, location, duration, characteristic, all of those factors, radiation, those things that you learn in medical school. I think that's great that your HPIs are so nailed down. What do you feel like are something that you could work on, or what are some areas that you think you could maybe do better in?
Well, I guess I could work on my differential diagnosis.
Okay.
Dr. Bradford keeps telling me that my differentials are not good, but I don't know how to make them better. And that's the only thing I can think of to work on.
Okay. Yeah, I think that's a very insightful. I think at this stage in the game, as you're transitioning from a third year to a fourth year, it's important to be able to build differentials. One way that you can do that, that I've talked with other students about, is if you're looking at algorithms on UpToDate, making sure that you're not just focusing on the algorithm for your specific diagnosis, but expanding that. And then there's also a website, the Diagnostic Checklist website, that Dr. Bradford can make sure that you have on your phone. But if you bookmark that on your phone, it's nice because it will give you a broad differential. And then specific to dermatology, there's an app called Visual DX that will let you expand your differentials based on what the rash itself looks like. So I think there are definitely ways for us to get better. One thing I've noticed is that your patient assessment needs some work. What exactly tends to be wrong with the patient, and what's your plan? You know, those sorts of things, you really got to think about, like, okay, what's going on with this patient? Where am I going with this? What's my plan?
Okay, yeah, sometimes there's just so much information and I get overwhelmed by all of it. It's hard to see the big picture.
I totally understand that. I think maybe something that may help us every day is to go over each patient and start with your assessment and plan so that we can work on that, especially since your history and physical, I'm very comfortable that you've nailed down.
Okay, that sounds good.
And then one more thing, I think one thing that we can work on is maybe humbling yourself, asking for feedback, which is a very humbling experience. And then also, chewing gum tends to be a thing that we probably should ditch. And the only reason I say that, in addition to sort of me thinking it's disrespectful, is that a lot of our older patients think it's disrespectful when we're chewing gum.
Oh my gosh, I had no idea.
Yeah,
Okay,
so-
I'll stop chewing the gum.
So those are some things we can work on, okay?
Okay, thank you.
Yeah, of course. So, Denise, how is Mrs. Smith today?
Well, I really think she's doing a ton better. I mean, she's sitting up in bed.
Okay.
She's not nauseous anymore. She ate her whole breakfast tray. She just devoured it. I was a little worried though because she was a little short of breath and just seemed like she was in a little bit of distress.
Okay, well, I guess one thing we should do is probably go up there right away. What do you think is going on with her, though?
So she didn't have any oxygen on, so I put some oxygen on her.
Okay.
I'm kind of thinking we should run a CT scan because she could have a PE.
Okay. Took it to a 10. What led you to that conclusion?
So she's been here, she had a stomach virus.
Okay.
Both her legs are kind of swollen. Maybe the right leg is more swollen than the other one. But she's just short of breath.
Okay. I want you to kind of walk me through your exam, too. Like, what else on the exam really kind of makes you think PE and not something else?
Yeah, so I listened to her lungs. Sounded like she had some reels. Looked at her neck. Her neck was kind of obviously had these like distended neck veins on both sides.
Okay, so JVD.
Like JVD.
Okay.
She has been on like fluids ever since she's been here.
Okay.
And I noticed that her weight was up. I don't think it's CHF though because she had a normal ejection fraction on her last echo.
Okay. Well, first of all, I think you really put some thought into this, and I really like that you're paying attention. You're very detail-oriented. The fact that you picked up on the neck veins and the lung sounds, that's very important. This was a really good presentation. I think that you walked me through exactly what you were thinking. One thing I think that you forgot is that, number one, Mrs. Smith, she's been getting Lovenox since she got here. So kind of factoring that into the thought of what would be contributing to a PE. The other thing is that a normal EF doesn't always rule out a heart failure exacerbation, especially in older ladies. They'll have preserved ejection fraction and they can still get overloaded. So I really like that you thought about everything, but I don't think we need to send her for a CT because I think a PE is less likely. And this is a very common scenario. You know, we have these ladies, we get admitted for dehydration, we put them on IV fluids, give them Lovenox, kind of forget the IV fluids are running even though they're tolerating PO well, and then they end up getting overloaded. The typical patient has heart failure with preserved ejection fraction like this lady, so we get a little too comfortable starting fluids and not checking on them. So I'm very glad that you did that, but I think that we should probably, just in general, in somebody with respiratory distress, it's good to get an ABG just to check and make sure there's not a respiratory process going on top of the fluid overload. Let's get a chest x-ray, stop the IV fluids, and then let's give her some IV Lasix and check her in a few hours. What do you think about that?
I think that's a great idea. You're
Okay.
really smart.
Okay, thanks.